First, before we talk about vaccines, I would like to make some comments about the pandemic response in general. Um, the number of cases that we've seen as a jurisdiction have kind of leveled off, and we're not seeing 500 and 600 cases daily. We are still seeing elevated case numbers in the upper 300s and 400 range, and our cases per 100,000 do remain over 30. Our test positivity has dropped slightly to, I think it was 6.1%, 6.19% yesterday, but we are still looking at elevated numbers. And when we look at our hospitals, I believe 3 of the 6 were in the red zone as of yesterday. So we continue to monitor those trends. Now, even in the setting of improvements, slight, albeit slight that they may be, we are continuing to monitor concerns for the presence of new variant strains of COVID-19 that have been demonstrated to be more easily transmissible. Yesterday, the state of Virginia announced that they had the first cases of the UK variant strain that were documented in the Northern Virginia area. And I believe as of this morning, there are over 200 cases that have been identified across the country. Now, certainly that suggests that the virus is obviously present somewhere within our community, given the proximity of those locations. And the state of Maryland, again, has increased their lab capacity to be able to do susceptibility testing for those strains that they get samples on to determine if there's any present within our particular communities. Again, there have been 3 cases identified in Maryland. None of those cases have been in Montgomery County to date. So I just want to make sure that folks continue to stay aware that we are still in an ongoing pandemic, and it's not just about vaccines. It's about all of those other continued measures that we put into practice. And this also underscores why we continue to have guidelines in place and restrictions in place related to the different activities that are allowed within society. So the next thing I want to move forward, I'll talk about vaccines, but certainly if there are any other questions about other aspects of the pandemic response, we're happy to answer them. This, again, slight adjustment to this on the right side when looking at the priority groups who we are bringing through the queues right now for the county apparatus. It's inclusive of all of those in priority group 1A, as well as now we've moved into priority group 1B to include adults over the age of 75. And so we have a number of folks who schedule with appointments today, and we are sending out the link for registration for the clinic appointments today, and consistent with what we talked about on last week, and we mentioned we are attempting to incorporate some principles of equity to ensure that there is, as best as possible, a fair and equitable platform and framework that looks at prioritizing those zip codes that have been hit the hardest, as well as looking at the racial and ethnic breakdown of those doses being allotted to individuals who are pre-registered. Now, one of the big concerns is that overwhelming majority of those who have registered using the pre-registration system does not match up to the population breakdown of Montgomery County. And so one of the strategies that I'm sure you'll hear about from some of the others, but what the ongoing work is to make sure that we reach out to those communities across the board and have a diverse sampling of individuals who are completing the pre-registration so that we can provide those folks with the links and continue to move forward. And so this breaks down and shows the distribution of vaccines that have been provided to the local jurisdiction, and this 43,790 number includes those doses released to the health department as well as to the hospitals and health systems across the county. So the percentage of individuals covered by the vaccine in Montgomery County is slightly less than the statewide average. But again, as we've talked about before, you look at our denominator, our total population, compared to the number of doses we received, and that can significantly explain that lag in the number. This slide breaks down as well what we just saw on the other side, the number of doses received by our jurisdiction, including first and second doses, as well as the percentage of the population vaccinated based upon the doses provided so far. And you can see, again, we are at 4.2% of our total population based upon the numbers that we've received so far. And this breaks down as of yesterday morning, the number of doses administered versus those received. We do anticipate, based upon what was delivered late yesterday, as well as what will be delivered today, will get us close to the total number of 31,500 doses that we've received, which is consistent with our performance so far in the 95 to 99% distribution range from a week-to-week basis. Now, we did announce that we will be receiving an additional 5,500 doses on hopefully this afternoon to implement into this upcoming week's allocation circulation. And again, our goal this week is to prioritize individuals who are over the age of 75 and to begin that process and get those folks covered. This breaks down, the number of vaccines received and administered by the health departments, as well as the percentage administered to date. And so again, you can see how we stack up against other jurisdictions, both in terms of the numbers we've received and the percentage that we have administered. And again, I do expect with yesterday's numbers and today's numbers, that 76% will be closer to the 95 to 99% range. This is a breakdown of the pre-registration statistics that I referenced. And as you can see, it is not overwhelmingly diverse and does not match up to the population distribution here in Montgomery County. And you can see how it breaks down by race and ethnicity. And that is a challenge. And one of the things that, there are multiple strategies that Dr. Crowel, and I believe Diane is also on the call, who will talk about efforts to increase that, as well as efforts to increase outreach within those respective communities to increase registration, but also ultimately increase uptake of the vaccine successfully in the future. This is a geographic breakdown of those who pre-registered so far by zip code, as well as a heat map. And this looks at the number of vaccines that have been administered within our health systems, as well as the percentage of those vaccines within those institutions that have actually been administered to staff or administered to others based upon those allocations. I just want to remind folks who are in our priority groups, again, who are receiving the vaccine. We are vaccinating, and the slides, the next couple slides are a little bit out of date, but we'll work with it. So everyone in Tier 1A, Group 1A, I'm sorry, and this is including all of our healthcare workers, Tier 1, Tier 2, Tier 3. So all of these folks are in the queue as well. We prioritized them last week. And the group that we are bringing on to prioritize this week are adults who are over the age of 75. Now, there are essential employees who are part of Tier 2, the 1B category, that the county apparatus is not prioritizing at this point. And this was part of a great number of the appointments that were turned away in the past week. Now, so just want to emphasize county apparatus prioritizing those 75 and older. And this breaks down who is defined in Group 1C, including those over the age of 65, and individuals 16 to 64 who have medical conditions and at risk of severe COVID-19. This is defined by us in Montgomery County. And this just basically takes what I just said and puts it in a different chart. But again, we are prioritizing 1A and 1B Tier 1 individuals over the age of 75. This just breaks down the number of doses we've received and we anticipate receiving for second doses in the future. Again, I want to emphasize that nothing has changed from how we are being notified in terms of the time schedule. We found out this week's allocation on Saturday night at about 7:30. The state is still finding out somewhere between Tuesday and Thursday, being notified from the federal government. And so again, we are at a week-to-week notification system. And part of the challenge, for example, is some have said, well, can we map out the system for weeks to come and based upon the allocations that we received before? That's tricky because, for example, there were a number of jurisdictions who did that and saw their vaccine allotments cut by 70 to 75%. And this week had to cancel anywhere from 800 to 1,100 appointments from individuals who have been scheduled because they based their clinic schedule on the allotments they had received in the past week. So that concludes that aspect of the presentation, but I would like to add a couple of other things in terms of updates. So you say we're moving to 75 and up, but the governor has moved the state of Maryland to 1C. What does that look like? Well, as the county apparatus, again, we are emphasizing and prioritizing those who are over the age of 75 this week. Now, we are working again to use that equity framework that I mentioned, those factors that we've discussed last week, and I just reminded you all of, to ensure as best as we can, or attempt to implement some equity strategies in implementation of those doses and sharing with the community. And so we are prioritizing that. Now, our community partners, including our hospitals, are standing up clinics that began yesterday. So Holy Cross and Adventist, for example, started providing access to community vaccination on yesterday. Now, they are going a little bit further into those priority groups as outlined by the state, including access to essential employees as well as individuals over the age, in some instances, over the age of 65. Those are specific to their specific clinics. Now, we had a great conversation with folks from Johns Hopkins. They received a significant tranche of doses this weekend and were directed to prioritize those doses to Montgomery County residents. Now, we aren't able to fully announce the plan. We're still working on some details, but those doses, we have been in conversations with them in the planning process. Those doses will help continue to provide vaccination to 1A and 1B, as well as part of their program, provide vaccinations to individuals over the age of 65. What we are most excited about in terms of, well, in addition to getting more doses for our jurisdiction, even if they're not necessarily coming to the health department, because our goal is to get as many people covered as possible, is that they are working with our education systems, starting with the public school, to be able to make provisions to bring in teachers and education staff to begin getting vaccinated in our efforts to cover our teachers and educators in order to move kids back to school, hopefully sometime over the next couple of months. Now, they have had their own conversations with NCPS, and we've connected them or connecting them with our partners in our non-public schools to be able to make provisions. And consistent with our previous conversations and exercises, we had asked each of those entities to prioritize teachers and staff who would be tied to those schools or opportunities that are most likely to come back at the early stages or at the initial stages of bringing kids back in. So that is in the works. Now, those doses that I'm mentioning is somewhere between 8,700 doses and 9,000 doses that the state made available to their system. Again, we've been working with them to finalize a strategy to share those doses within the community to hit all of those key points, as well as make sure they implement some level of equity strategy in rolling that out. Now, in addition, this week, there are a couple of other sites that received a small number of doses, including giant pharmacies throughout the county. We, as the county, don't have any role in distribution of those. And so if there's specific questions related to that, we would encourage folks to contact those stores directly to find out more about their distribution patterns and their particular protocols. The last thing I will mention is that we also, and I anticipate we may have some questions since I talked about schools, is that there's been a lot of information and conversation back and forth about the governor's pronouncement and where we stand. I want folks at home to understand that there are no absolutes in this discussion. Everyone, it's easy to quote and say it's absolute science that tells us we need to do this, or absolute science that tells us we don't need to do that. we remain hopeful that this is the opportunity to have a robust discussion about what are best practices and what things may be able to be tweaked in terms of moving kids back to school. And our task is to vet that information and to vet the studies as they come through to be able to provide comprehensive guidance to our non-public schools, our public schools, to help them in that decision-making process. So I just want folks at home to understand that we're working on that. And trying to put together as much information as we can. We continue to get emails, equally passionate on both sides or all sides of that conversation in terms of getting kids back to school. We do think that by getting teachers and educators vaccinated, that will be a tremendous help in that conversation because it will offer additional protection to our teachers and staff who may be at risk once that kids are brought back into school for in-person instruction. I will stop there and turn the floor over to Dr. Stoddard, but as always, happy to answer any questions you all may have. Thank you.
Thank you.
I would actually suggest Dr. Crowel go first, and I'll clean up and cover anything that he doesn't, because he's been substantially engaged on many of these issues.
Dr. Crowel, thank you.
Okay, good morning, everyone. Thank you, Dr. Stoddard, Dr. Gayles. Want to start with a couple of things, and just to say that we are going to give you some updates and talk to you a little bit about where we are on vaccine registration and scheduling, and talk a little bit about the demographics to date, sort of underscoring some of the things that Dr. Gayles talked about. And then I want to talk a little bit about the work of the teams that have been in place, and to talk about that from a framework around equity, and let you know what we are doing. The first thing around registration and scheduling that I want to share with you is that we have been working on pre-registration, standing up pre-registration for tiers in 1B and 1C. And that pre-registration site will be launching today at no later than noon today. So waiting on a few last minute translation issues so that we make sure we can launch concurrently in at least 2 languages and in other languages as we go forward through the week. But it will be live, hopefully it will be live today. One of the things we're working on in this is that we've had some challenges, as you all know, with registration and people registering before they should register, not at turn. So we're working with to develop a process that allows those who live and work in Montgomery County to pre-register, but also looking to provide some unique identifiers to folks so that the person who gets the email to pre-register has a unique identifier that is only associated with that person. That'll help us, we think, keep us intact and honor our prioritization, and hopefully keep our efforts to promote equity in this process alive and well. We are also, well, let me just back up for a second and talk about the registration at this point and the numbers around pre-registration. To this point, we have pre-registered something on the order of 96,270 some odd people as of Sunday. I don't have yesterday's numbers on this, but as Dr. Gayles points out, we have some not surprising disparities in terms of registration. We have about 71,000 of those are white, about 5,000 and 5,500 are Black or African American, about 6,000 are Hispanic or Latinx, and we pre-registered and announced pre-registration for 75 and older. However, that didn't stop other folks from logging on and pre-registering, which is fine. We'll work through that. But the 75 and older group numbers about 62,000 folks. So the disparity that Dr. Gayles noted earlier in terms of the pre-registration and it mirrors some of the healthcare outcomes, and also think that it points to both comfort with accessing online service and also awareness of registration. We did do an incredible effort from our communications team and the folks that I'll talk about later in our community partners and getting the word out to folks. But clearly, we have a long, hard lift ahead of us to make sure that the communities who have been most severely impacted by this are engaged in registering to receive the vaccine. We have we are also working on, and should be up to date, establishing a call center for folks where we will assist with pre-registration. It's not a Q&A call center. It is primarily focused on pre-registration for folks who are digitally challenged and or who have limited access. That's a thing we're going to have to work on most broadly, I think, as we go forward. That the access is going to be an ongoing challenge for many folks, I think, not just our senior population. The group today will be pre-registering in 1B and C, but 1B is we're now in the process of scheduling up for seniors who are 75 and over, and those folks are being invited and asked to schedule up in Prep Mod and come in and get vaccinated. The next group in this process are in 1B and 1C, and we're inviting them to pre-register, and we'll following that up at some point as we complete our vaccinations of 75 years and older. We will then invite them to schedule a time. So folks are going to have to be patient. You know, Dr. Gayles has outlined the numbers and the limits of vaccine and capacity. So we are constantly trying to expand that, but it's going to take some time. In terms of equity around this, everything that we are doing at this point is combined to make sure that we can get people into a chair where they can receive a vaccination. That is an equity, and in thinking about equity, we're thinking about not just the process of how the vaccines get distributed, but a whole series of things: where we're vaccinating, when we're vaccinating, our engagement with the communities and community partners to identify and address barriers and to get community partners to help us to knock down those barriers. Communication about the facts of vaccination and on addressing some of the hesitancy issues. In terms of distribution of vaccines, that is a challenge around figuring out how to do that in a way that is fair and equitable. And we've had some preliminary conversations, and some of you have weighed in on and given us your thoughts about how best we do that. This week, we are looking at communities that have been hardest hit, and we are, as we speak, this week the invitations or the appointments for vaccination are being assigned to the top 5 zip codes that have been most severely impacted by this pandemic to date, and where the virus has its strongest toehold in the county. 90202, 04, 06, 208, 50, and 52 have the highest number of deaths in the county, so it's where we've started this week. We're also mindful that all across the county we have pre-existing disparities that have increased vulnerability in our Black and Brown and Asian communities. And so part of the process is, part of what we're looking at, part of what we're doing is making sure that doses go to members of the community where the virus has hammered us the worst. So communities, again, of color that have been hardest hit will get a share of the doses, and be invited in proportion to the level of impact of the virus on those communities. As a practical matter, attacking this virus in places where it has the greatest toehold, where it has had the greatest impact, is how we're going to kill it. It's where we see the greatest spread that we have to start this process and vaccinate. Our latest pre-registration data points that I just shared does point to the need for some intensive outreach and communication. And we've started that process with town halls that you all have hosted and have participated in, and we'll continue to do that, along with regular updates that you all are helping us to push out and from through partnership with our PIOs. But also working through our current partners in the testing initiatives. Salud y Bienestar is working, as is the diaspora initiative that's being coordinated by the African American Health Program program, and talking with them about surveys and information sharing with the public, but also now looking at retasking some of the case management support that's already in place and in the communities, with helping people with messaging, but also helping people to register online. This is something that everybody can take a task, can take a hand in it. We've got pre-existing capacity, so it makes sense to make use of that. We're also making use of the census team. The framework that was put in place by Diane Vu and the Office of Community Partnership to make sure we got people counted in the census is a pre-existing framework that it makes perfectly good sense to use. And so almost for at least over the last month now, Diane Vu and her team have been at the table as we think about the communications process, but also as we think about outreach to the community. And joined by the Regional Service Center directors. Ken Hartman is here with us today representing some of that process, but making sure that we have the partners in place that can reach deep into the communities. Part of that process for us is engaging with the faith communities to help them both with messaging and helping to get folks into chairs. Nonprofit providers or providers in the county, Montgomery, the public school system, and our hubs, all of whom have to play a role in this. They are already in those places, and it makes sense to use their ability to reach to get people pre-registered and into the system. The challenge is not just to communicate, but it is also to identify the problems and challenges that our communities are going to have getting access to vaccines, from pre-registration all the way to scheduling and getting to a location where they can get a shot in the arm. And not just to identify those challenges, but to help in the process, to be able to stand up and say, I can help do this, whether it's transportation or whether it's identifying sites and helping to host sites where as time goes on, we'll be able to stand up vaccination opportunities. So that's the broad framework of how we're thinking about equity, not just about where the doses go, but how we do everything we can to get our community into vaccinated. Time check. We are 1 month into this process, just a shade over 4 weeks since the first vaccines became available and started being distributed to folks. And that's a time check. If you look back at all the things that have changed and all the things that are going to continue to change, it will give you a sense of how far and how fast we have gone in the last month. We are in constant forward motion on all the fronts that I've talked about: community partners, communications campaigns, and vaccination. And recognizing that this is going to be an extended effort, it is going to be the better part of this year that we're going to be engaged in this process, I think, until we are vaccinating more fully and have the majority of our community vaccinated. All of this is continuously changing, and we will be adapting and changing how we message and how we distribute vaccines as we go forward. That equity process I talked about and sort of thinking about the actual distribution is going to change as we go forward, and we see places where we are missing or places where the virus is spiking up, and we need to adapt continuously around that. I think I'm going to stop there because I know there's a lot of questions, a lot of conversation that folks want to have, and I do want to give Dr. Stoddard a chance to jump in with anything else that I may have missed.
Thank you.
You didn't miss much, Dr. Crowel, so I won't go too long here. I just want to reiterate a couple of points that have been made, particularly on this issue of the sharing of the links. I think this is an absolutely critical point that we have been trying to hammer home. The state system currently does not allow us to limit to a unique identifier the links that are sent out for an actual registration, not the pre-registration, which we own, the actual registration for our clinic time and site. And what's happening is people are stripping away all the instructions associated with those links and sending out just the bare link to the wild, as it were, their friends and their family, their listservs and others. And people are seeing those links and in their desperation are signing up for sites to receive vaccine. Unfortunately, without any of the descriptors on those clinics, some of those clinics are second shot clinics, for example, where people, where the primary focus is getting second doses to people. And we are actually prohibited from giving by the state, prohibited to give second doses as first doses. And so obviously people are signing up for things that are not real opportunities. And then we look like the bad guys when we have to cancel out their appointments because we won't have vaccine at that clinic to offer them. And so obviously this is a huge problem. This is one of the things the county executive did speak with the governor about yesterday. This state system is great in a lot of ways. It allows for identification and mapping of locations. It's just not designed for a pandemic distribution where you have more people interested in receiving the vaccine than you have doses. It's built for a seasonal flu or a childhood immunization campaign where your goal is to just get as many people as who will receive it opportunity. And so it certainly was shared with the governor, and he did understand and was going to take it back to his team. to take a look at the PrepMod system just to allow for when we send an invite out to somebody, that's the invite for them and not the invite for them and their 5,000 closest friends. Obviously, as Dr. Crowel said, we are not interested in having this be a vaccination campaign where it's about who you know. We want to make sure that there's equity and other principles reflected. And the only way we can do that is if the person we send the link to is the person who uses it and not some extension of their network. And so obviously we do not like to cancel appointments, but frankly, we will continue to do so as long as people continue to share them and spread them inappropriately. And we want to get that message out there very clearly. We don't think people are doing it necessarily to be devious. Certainly the people receiving it don't know that they're doing it because they're not receiving the instructions, but the people sharing them absolutely do know. There's at least 3 times in the email with the link that explains that you should not share this link. But people are doing so anyway, and this is it's slowing down the process, candidly. There are days when less people are getting vaccinated because we're having to keep, we clear out the people who shouldn't have been on there, we reopen it, they fill it back up, we clear them out again, and it's just a constant battle. It's not like you can check one time and you're good to go, because people will just, you'll clear spots and people will still have the link and they'll re-up right into it. And so it is a problem that we will have until the state is able to correct their system. I also want to highlight Dr. Gayles talked about the partnership we have with Hopkins. We are also working with the other hospitals. We're currently in a strategy right now with Holy Cross where we're actually prepping their professional building to have a large vaccination site. We have DTS working on IT infrastructure in the building. We have our Department of General Services working on furniture and other resources for in the building. And so it will be a true collaborative. They ultimately believe they'll be able to do 1,500 doses a day at that clinic once we have the doses to do. And so obviously, we're talking about the Hopkins thing because it's this week and immediate, but there are other collaborations that are going on with our hospitals. Our hospitals are also doing very community-based vaccinations. I know that some of our senior locations have received vaccine this week. I believe that they were out at Leisure World according to Delegate Cullison this week. And I also believe that they were at Asbury and Riderwood this week doing clinics there. Those will continue. I do know, for example, the Leisure World clinics have been paused because they ran out of vaccine. And so obviously that's going to be fits and starts, and that will be a challenge that we move forward. But one of the big, I want to talk a little bit more about what we talked about with the county executive talked about with the governor, just so everyone's aware. We did request, and I'm already seeing media talking about what we're talking about this morning, and the governor's comm staff responding to it. So I think it's really, it's sort of an interesting in real-time conversation. Certainly, it was a very good conversation between the county executive and the governor. It was actually incredibly positive on all accounts. One of the big things that we requested was, we know that the state is limited to what it gets, and they get their information as the governor's comm staff said today. They got it at 7:30. They sent it to us at 7:30. Well, I think what we actually are suggesting, what we actually requested of the governor is, if you tell us that, we don't need you to tell us that we're going to get 7,000 doses a week. If you could tell us we're going to get 2,000 or 3,000 at a minimum a week, we'll schedule 2,000 or 3,000 worth of appointments. And then as we find out we get more, we can add appointments on, as opposed to, that would allow us to do much more lengthy clinic planning. We're really not keen on creating clinic opportunities and having to cancel them. And so that was one request that we did make. And the other thing we wanted to talk about is the fact that this is a holistic countywide plan. As the county executive said to the governor, we don't care if Hopkins gets 9,000 and we get 5,000, or we get 9,000 and they get 5,000. As long as the appropriate number of doses are coming into Montgomery County, and we can work with our hospital partners and others to ensure that the groups collectively are being addressed. That was the important thing to us. And so, while the local health department is not necessarily moving into 1C and doing 65 to 74, we did talk to Hopkins and agree that they absolutely could do 65 to 74. And so functionally in Montgomery County, people in 1C will be vaccinated. It's just different clinic opportunities are focusing on addressing different challenges and different inequities. And it's a partnership of all those opportunities that adds up to what's happening in Montgomery County, not just what the Department of Health and Human Services is doing or what Hopkins is doing. there is some synergy and some strategy into targeting different groups by different opportunities. And, I think that's clear, and the governor was supportive of that, asked us to sort of draw that up as a plan, how we're working together with our hospitals. And, that would count towards the overall effort that Montgomery County is doing. So all around a positive conversation. That's all I wanted to add. And I think, I don't know if Mr. Hartman or Ms. Vu have specific comments they want to provide in the beginning, or if they'll just be here to help answer questions.
So Dr. Stoddard, just one other thing to note that is in relation to the collective plan and the collective effort for distribution of vaccines, that as other providers come online and that distribution spreads to private primary care docs and hospitals and drugstores and other places, it will allow us in the county to more tightly focus our efforts on how to reach communities and residents. So it is a collective enterprise, and increasingly that's the direction we're going to see it going in.
Terrific. Thank you all so much. And obviously we're all grateful to Hopkins and Holy Cross and any of our hospital partners for initiating more collaborative help to get our vaccines into our residents. That's really welcome. And we want to keep it up. Okay, colleagues, 5-minute rule. Council Vice President Albornoz will lead us off.
Thank you. I'm going to have to go back in the queue, but even this morning, just being bombarded by emails, questions, phone calls, people who are frustrated, angry, scared, disoriented. And so I want to attempt from 30,000 feet to explain the overall picture. This is more for our residents, and I want to ask the team to correct me if I say anything wrong. So here's the situation. Federal government is working directly with Pfizer and Moderna to distribute the vaccines to the states. The federal government strategy has been fuzzy and has not been transparent. And the Biden administration is working on accelerating both a better distribution plan and hopefully help those two companies and the others that come online produce more vaccines. States are responsible for devising their own strategies on how they're going to disseminate the vaccines to their constituents. The states are responsible for disseminating the vaccines to local county governments. Maryland has been receiving, on average, approximately 70,000 vaccines, per week. And they made the policy decision early on, and as Dr. Crowel noted, we've only been in this a month, but that the distribution of those vaccines would be consummate with the population of each of the counties. Montgomery County's population is between 18 and 20% of the state. So we've been receiving on average about 18 to 20% of the vaccines made available to the state. Here's the problem with that, because on the surface, that makes sense. Talbot County, which is leading the state in the number of people vaccinated, has a population of 37,000 people. The city of Rockville has a population of 67,000 people. Montgomery County has over 60,000 residents over the age of 75. Talbot County has 1 hospital, and we have 6, along with all of our other medical and healthcare providers. And so even really, getting as a percentage of the population, Talbot County has been able to move on to 1C. And so when the governor makes an announcement in a press conference that the state of Maryland is moving to 1C, it is true for those smaller counties that have fewer people that they have been able to move forward with 1C. Montgomery County has not, because we have a significantly larger population, a larger population of people in the 1A category, a larger population of people in the 1B category. And we are among the best in the state in being able to turn around the vaccines once we receive them to get them into people's arms. But because of the mixed messages that our constituents understandably are confused by, they continue to wonder why Montgomery County has not been able to more robustly move forward and be at 1C when all of these other counties have been able to. How am I doing so far? Is that accurate so far?
Yes, you are very accurate.
Okay. So now here's the new challenge. We are being able to disseminate this through not just the hospitals now, but also our own administration We're adding Giant and the CVSs and the pharmacies, all good news. But because we don't exactly have a centralized registration system, and because the registration system we in fact do have is easily spread to other people because it didn't have the controls in place, we now have what feels like the Wild Wild West, in which people are signing up wherever they can, in as many places as they can, because they are scared, because they are disoriented, because they are hearing messages from the governor that we are on to 1C, and that is gumming up and creating a bottleneck across the board and confusion among all of our residents. So far, how am I doing?
Again, you are very accurate.
Okay, so where we are right now is the good news. The county executive had a successful meeting with the governor yesterday. The governor's comms team announced that 18,000 additional vaccines were going to be made available to Montgomery County. So I want to confirm if that is actually in fact true. That's going to be my question in this first round of my queue. And if it is true, how are those 18,000 going to be distributed? Are they going to be distributed through the hospitals? And I understand we don't care, and I get that. The important thing is we just get them out. But what is the plan for those 18 additional thousand that we're going to receive, if in fact it is 18,000?
So I think and others can chime in on this as well, is that the number that the governor's office tweeted out yesterday was inclusive of the 9,000 additional doses coming from the Johns Hopkins allotment. And as we laid out, we met with them this weekend. They reached out to us on Saturday when they received notification that they were receiving those doses. And we engaged in conversations on Saturday and Sunday and ongoing conversations about how to allot those doses within the community. And so their key areas that they're going to focus on are folks who are 65 and up. And they have had their own conversations. We've helped connect them with their school systems to discuss creating a system where we can bring in educators and educational staff to also be able to utilize those doses in the first week. My understanding is that they have received that allotment for this first week. I don't think that they have received confirmation as of yet about following weeks, but the expectation is that if everything goes smoothly, there would be further opportunity to increase the dose or to continue to provide them with doses to be able to support the county by providing extra doses to other folks. I think
It does. You nailed it. Final comment, and then I'd like to be put back in the queue, Mr. President, just really quick. My colleagues and I, a letter is going to be distributed to all of my colleagues. We had agreed last week we're going to send a joint letter to the governor with a series of follow-up questions and concerns that have been raised by constituents. I want to thank HHS for helping us, and Linda McMillan and my staff and my team for working on the production of that draft letter, which all of my colleagues will receive this afternoon. Our hope is to send that letter tomorrow to the governor, following up with very reasonable questions of our Secretary of Health to clarify some of the issues that we don't have control over here in Montgomery County. And we do, again, appreciate the governor's very productive and positive meeting with our county executive yesterday. It's something to build on, but there's obviously a lot more that needs to be done. I'll come back with more questions, Mr. Council President, in the queue, but I'll defer to my colleagues for now. Thanks.
Thank you. Councilmember Katz.
Thank you very much, Mr. President, and thank you to all the doctors and to the vice president of the council, because you truly are narrowed it down to concerns. There are so many issues that we're dealing with, and there's so much communication and candidly miscommunication on what people are hearing that it has become a real problem. Just this morning, again, we have heard from people in the developmentally disabled community that when they register or attempt to register for their child, that they're not given a confirmation. There's not a drop down on the fact that someone would be 30, 35 years old, and then they would get thrown out of the queue. There's nothing that says that that person would be eligible at that point when they register. Is there any way we can correct that?
It will be corrected today with our pre-registration site does have a selection option for intellectual and developmental disabilities. You can select it right as a choice, as an option, and that'll be corrected. As Dr. Crowel said, that'll launch by noon. So within the next 90 minutes, that will be an option for people to re-register.
Can't ask faster than 90 minutes, Earl. I think that's fair. We did receive, and I sent it on to you all, to the doctors, about the public defenders, that they go into the jail and other places, and that is there a way that they too could be considered under public safety?
They are on our prioritization list. I believe they are in 1C. I know we're also talking to the county attorney's office, which has the same considerations there. So they also will be able to pre-register today, so they can go ahead and start getting in. Obviously, we'll have to have a conversation about whether we're going to, public safety or not. But I think that certainly they're able to pre-register, and we do have them in a priority group in 1C.
All right, and so that's the next question. For 1C, there's been misinformation or information that gets confusing on 1C. So today, Sydney Katz, who's in 1C, could register on the county website. Is that correct?
Yes.
Anyone over 65. And is that at any time today, or is that a certain time today?
We are opening up the registration, I think, to all the categories today at the same time. I would say to folks that it's important to understand that pre-registration does not mean that you have an appointment for vaccination. It is pre-registration that gives us a list of folks that we can draw from as we complete our vaccinations in earlier phases and with earlier populations. And it is not a first come, first serve registration. So there is no need to rush to register at noon. Register as you can. We're vaccinating and scheduling 75 plus, and that's a group that we certainly want to encourage to register as soon as they can, so that we can get them into the queue. But the other categories, take a moment, find a moment, and pre-register. There's no rank ordering of this.
I will also pass that along to my wife, who always wants me to mention that I married a much younger woman, and though she happens to be in that 1C category, and I will pay dearly for that information. On the possibility of fixing whether or not about multiple, someone would register for CVS, and someone's going to register for Holy Cross, and someone's going to register with the county. Is there a way that we could have a single, and I think the Council Vice President also brought this up, is there a way that we in the county could have a single registration, and that the county can figure out where you can get that vaccine?
So I would say, go ahead, Dr. Gayles.
I was going to say, so part of what complicates this is that in the health department, we're required to use the state system, the PrepMod system, and all of the private entities use different portals. So, I know Hopkins uses MyChart. I honestly don't know what the retail pharmacies are using in terms of their registration. I anticipate it's not PrepMod. And so that creates some of the confusion within that. Dr. Crowel?
Just wanted to say that pretty much what you've said already is that they're separate systems. And at this point, we are sharing with them our concerns and our thoughts about equity, so that they can hopefully apply some equity principles as they think about how to register and vaccinate people. But we don't have a capacity there's no unified system at the state level that will allow us to do that right now.
Thank you. Mr. President, am I at my 5 minutes?
You are.
Thank you, and could you please put me back in the queue? If the questions are answered by others, I will not be going back in the queue. But at this point, I do have other questions. Thank you all.
Thank you. You are back in the queue, Councilmember Glass.
Thank you very much, Mr. President, and thank you to our doctors for providing all the information that you have today. We are 1 month into this process of vaccine distribution, and people are frustrated. They're anxious and they're worried. And these concerns are only compounded when state officials continue making broad statements about eligibility. They recently talked about expanding eligibility, and the expansion is 3 times as large as the vaccines we have available. And I think the governor needs to deliver, because people are desperate and they're asking us for help. They're concerned about their lives and concerned about the lives of their family. And the governor needs to ensure safe, fast, and equitable distribution of these vaccines. And by looking at the metrics that you've shared with us and the metrics that I've seen elsewhere, fast, safe, and equitable distribution is not being done. Other states have centralized their systems, realizing that counties are competing against each other and that residents are going to other jurisdictions. And that's why we need statewide leadership. Just as we have federal leadership now in President Biden, who is taking the reins and trying to get a hold of the situation, we need the same in Annapolis. And during this conversation, I received the email from the county announcing that officially we are vaccinating individuals in Group 1B, which are teachers and childcare workers, essential workers, and individuals with developmental disabilities. And so my question about that expansion is, how do we vaccinate essential workers and childcare workers who might be undocumented? What is the threshold for them to be able to safely get vaccinated?
So at this point, I can certainly say to you that there is no criteria around residency status or immigration status that governs vaccination. People who are eligible by the tiers can sign up and pre-register, and when it is their turn, we will invite them to schedule an appointment and get vaccinated. We're not asking questions about the immigration status of people. And
so what is, for lack of a better term, what are the requirements or the documentation to show that somebody is an essential worker?
That will likely vary by depending on the group that they're in, but there may be some identification or something that verifies that they're working for or in a setting that meets the criteria for essential worker.
Okay. I hope
I'll just add you asked about the childcare specifically. So for example, right now we obviously are focused on licensure requirements through the state, but as you've correctly noted, I think we do know, and this was brought up, we've actually been talking about this on our vaccine coordination calls, that we do know that there are sort of unlicensed childcare providers who are operating, particularly in our communities of color. And that's something we're going to have to deal with on a sort of a specific level, because I think the other side of it is if we have no documentation requirements, suddenly everyone becomes a child care provider. I think you can understand what happens there, right?
Well, Dr. Stoddard, that's why I asked the question.
Right. So we're working on that. Yeah.
We are absolutely sensitive to all of our residents and everybody who works here in the county, who are neighbors and friends, and we want them to be here. We don't require documentation for any other county services, but I ask because I'm not quite sure how we move forward and provide vaccines without some level of veracity to the work that they do.
So that's always going to be a challenge for us, is sort of verifying that folks are doing the work that they say they're doing when they sign up for us. And this is clearly, pre-registration is very much an honor system. It's at the point where folks are scheduled, and as that they're going to have to share and demonstrate that they actually are in the appropriate point in the queue to get vaccinated. The other piece of this, and childcare is a good example of this. There are licensed childcare providers across the county, and we're working to identify those folks with the state and with the school system and our childcare community, and figure out a route that gets them safely vaccinated and have the appropriate identification. But there is an informal economy that operates in Montgomery County that we have to think about it at some point, because we have people who are putting their children in the care of folks who are unlicensed at this point. And while we want them to use licensed providers, I know that is not happening. So we have to ask our community partners to help us think through what we do and how we deal with those kinds of issues as we go forward in terms of getting vaccination to.
Sure. Well, and if we want our community partners to be engaged in that, we have to engage our community partners. And so make sure that's an ongoing conversation. And I know my colleagues and I will have our ears to the ground to make sure that there are no holes in this process and people who need these vaccines and are in fact essential workers as classified by category 1B, that they get the vaccines they need.
Yeah, we are focusing on tier 1 first. So we do, unfortunately, because there are 70,000 people who are 75 and older, and we're getting 5,500 doses a week, it's going to be some number of weeks before we move into some of those categories. And that is going to be the focus of our next few weeks to try and figure out how exactly we'll make that functional.
Sounds good. I see my time is up. I'd like to be put back in the queue. Thank you, Mr. President.
You bet. Councilmember Navarro.
Thank you so much. Very important conversation. It is absolutely true, Dr. Crowel, there is an informal economy in our county. That's kind of like what compelled me to launch Centro Familia, because we know that there is a lot of unlicensed childcare in our communities, not just in communities of color, I might add, because the cost of childcare is so high that undoubtedly this has been a challenge for us for so long. But the good news, I think, and I will address that first, is that as we talk about these challenges around equity and challenges around identifying this informal economy issue that is so critical, the good news is that we do have a pretty strong infrastructure. We've recognized that. And so I think that as we marshal the efforts through our initiatives, through our hubs, through the partnership with our Resource and Referral Center, with the different childcare associations, I think coming together and marshaling these resources, we can really do a great job. I am a little concerned about the capacity of the initiatives. I'd like to add our Asian community. I know their health program, we've heard from them, the hubs, et cetera. I'm a little bit, concerned about their capacity, and we'll be circling back with Linda McMillan and you, Dr. Crowel, to talk a little bit about that, because I do think that we need to enhance their capacity there. They can literally move their sort of, outreach engagement regarding the pandemic and the testing, et cetera, that they've been doing thus far. They can add to that this vaccination issue. And I think that we can definitely count on all of them to help us address what we saw on those slides regarding the inequities that are already being manifested. And so I'm looking forward to really figuring out how we provide the appropriate resources so that they can continue to do what they do, plus all of this. Also, just curious about some conversation that I know I have had before, both here and also on our Friday briefings, regarding this idea of standing up almost like a navigator team of sorts. As I've heard all the updates from Dr. Gayles, Dr. Crowel, Dr. Stoddard, it is clear that everything is just shifting on a daily basis. Councilmember Albornoz was awesome. I'm so glad you're literally our spokesperson, because you did summarize this so well. But there's no doubt that we have got to continue to do not only the communications, but also troubleshooting. Is that a concept that is being considered? Has that happened, to have literally like a navigator team of sorts, that whenever there are questions that come up, we all get questions asked? I don't feel, I feel a little bad when I have to call or email or text Dr. Gayles and Dr. Crowel during the weekend, because, maybe one of our delegates is asking a question. Can we stand something like that up so that there can be a much more streamlined way of troubleshooting and also just getting information back and forth to us as elected leaders, but also the different, leadership and kind of, be able to filter that in terms of what the community is asking.
So my first reaction to that is that there's a weekend.
I've heard about that. It's kind of like something that used to exist.
There's this rumor that this thing called the weekend. I would say to you that the work that we're doing with Diane Vu and our community partners right now is not just about messaging out to the community and doing that in an efficient way using the census backbone that we're talking about. But I also think that in terms of navigation, the piece that we're looking to do as we go forward is to engage the community so that the community partners know where and how to guide people. We are standing up both a call center to support seniors, but a piece of that unquestionably is going to be Q&A and central points where folks can call and or email and get us and ask questions. Right now we have HHS Mail that is a central point where people can email their questions, and we have a team that is dedicated to working on getting answers to those questions. I know some of you all have sent questions over, and we're using that same process to centralize information and get information back out to people. We use that as a guide. We answer the questions directly, but we also use that as a guide for updating our FAQs and information, both on the website and in the daily updates that we send out to you. We are going to need and stand up as we do registration teams throughout the county, I think, that will help folks to get registered and to get to and to get scheduled for vaccination. But also, and this is to my earlier comment about the community partnership, we're going to need folks who can help us to sort out how to get a person to vaccination, to a vaccine point. Do they need an appointment? Do they need rides?
Yeah. So I wanted to clarify. So I feel like, I guess my question had two parts. So one of them is, what we're going to do with the community. And I think that we've got those pieces in place. We just have to perhaps, add more capacity. The other piece was more like a rapid response, in real time, troubleshooting questions that do come up to us or things that we're hearing in the community. Obviously, you guys are super busy. Do you have a team within HHS that is sort of, constantly interacting with Dr. Stoddard's office, with Dr. Gayles, et cetera, so that there is a quick response, almost like an emergency response type of situation just regarding the vaccine issue, since right now it's just so confusing. So I termed it, a navigator team of sorts, could be rapid response team or something like that. Do we have that? I know other jurisdictions around the country have done that, so that we can then deal with this issue of communication in real time.
I would say we feel like we're dealing with communication issues all the time in real time. So it's hard for me to say. We don't have a centralized number because the issues right now are legion and they come from everywhere. So there is an effort to stand that up and to try to streamline and integrate our communications. So if the question about vaccination at an appointment site is the question about an issue about when am I and where am I scheduled, we have to triage the questions, obviously. So one of the things we set up for you all was a process to get questions and figure out how do we and put them into a queue to answer so that we can do some answers to questions that are not crisis questions, but urgent questions that need answering. It's a fair point, and give us a minute to think about how we do that so that you can have a faster route to I would ask two things. One is that we will find a route to give you quick access. If you all can think about how you triage the question so that not every question that you get asked is a gotta have an answer right now question, but it's the more that there is some sense of what's an urgent question from you all versus one that we need a little more time to and can have a little bit more time to develop an answer.
If I may, I think the one challenge that we all face is that because this is moving so quickly and it changes on I won't even say daily and hourly, maybe too generous, because there are things that I think that the problem is if you have all the information, it's because you're in the game. You're doing the planning of clinics. You're on. It's not just Dr. Crowel, myself, Dr. Gayles, Dr. Bridgers, Sean O'Donnell. We talk about Mark Arsenal. There's a whole team of individuals in HHS and in my staff who are intimately involved in the planning of clinics. But the farther down the chain you get, the more niche their knowledge becomes about the particular mission that they have. And if someone is, if there's a team that knows, I won't even say I know everything about everything that we're doing because there are things happening in HHS, and I'm sure there are things happening in emergency management that Dr. Crowel doesn't know about. So the problem is, if there's like this team of ultimate knowledge people, it's a very small group of people, and you're probably looking at the majority of that team. And so I'm not being dismissive to your point, but I think the concern I would have is, in order to be responsive to what you're saying, which is a rapid response to a question, not knowing the nature of the question, there are probably a very limited number of people who can answer it.
I think, yeah, that's the.
I appreciate that. I know my 5 minutes are. I appreciate that. I just think that we should think through this a little bit more, only because, and I'm not talking about run-of-the-mill questions. I'm talking about things that might come up that are of, grave importance, et cetera. How could we quickly be able to access, a team within? And again, it's not for everything, but so that we can have that, situation in real time. I think that's going to be critical as we are going to get into more and more complexity regarding the vaccine issue. So we can talk about it, a little bit more, but I know I brought it up several weeks just because it seems like there is a need for that.
I do want to say that as we go forward, that the challenge it's two things. I distinguish between a question and answer issue where we're trying to get answers to questions versus where we're trying to get some help and some support to someone who needs some support in a quick way. And when I think about navigation, I think less about the Q&A and more about the response needed to help somebody get to what they need and as quickly as possible.
Right, and because there's so many layers, I feel like we need more than just you guys, I guess is what I'm trying to say, because there are just way too many layers. So it's not just an answer, but it's how do we troubleshoot what is happening. Thank you. Anyway, I went over apologize for going over. Thanks.
Who's next?
I'm sorry, Councilmember Reamer. Didn't realize I was muted. Sorry. Those darn kids.
Okay. Great. Well, generally, I want to say I am very glad that the governor has shaken up the distribution model in the state, because we had to make a big change to get doses administered more quickly. At the end of last week, according to the state's website, still fewer than half of the doses that had been sent out to counties around the state had been administered. More than half had yet to be administered. And that is a national problem. It's a complicated problem. It's happening throughout the country. But the shift that the governor made to open up eligibility, while it has created chaos because of other problems with administration, it is resulting in an acceleration of the administration of doses. And I'm optimistic that we're going to start to see the successful administration of a much higher share of our doses now, because they're not going to be sitting on shelves at providers. I really feel so strongly about getting seniors inoculated. And if it wasn't for the state change to direct the hospitals to start dosing seniors, they'd still be waiting. And that would have been that's untenable. So now we have seniors starting to get inoculated. I don't mean to excuse the state for its general failure to build an effective and unified registration system, for example. I think that is really inexcusable. But it is good that seniors are getting dosed. We have to remember that seniors over age 80 are only 2 to 3% of our county population. They've been over half of the deaths from COVID. But the state shift definitely has consequences. One issue that we have now is that we are telling everyone to pre-register at our website, but as you've explained, the state is shifting its doses from the county to private providers, essentially. And so it may not be clear to people that they are now pre-registered with one of the providers, not all of them, and that the provider that they've registered, we don't know how many doses that provider will be getting from week to week. And so they will need to both register with the county and with private providers, or monitor clinics from private providers and try to sign up through all of these means. I think that many seniors are aware of that, but I don't know that we're communicating it as much as we may need to. I'd like to go to the issue that Mike Ricci tweeted out the county's allocation of 18,825 first doses this week. Dr. Gayles has mentioned 9,000 went to suburban. You're describing a plan to allocate a set number of those for the education sector. I would really appreciate it if perhaps next week we could get a presentation about the plans for education vaccination and how it fits into a multi-week strategy. The 5,500 that came to the health department for this week, we've just been notified. It's opened up to 75 plus, which is good. There were 1,000 doses sent to NIH. Are those just for NIH, or are those also open to the community?
Those doses are for NIH staff. And for that, yes.
Thank you. That necessary. I heard from NIH workers who had not been able to get dosed. And then 1,600 doses have gone to Giant. So Adventist, Hopkins, Holy Cross, MedStar, they still have doses on the shelf, which they are now getting out through their own clinics. And that is how 1A, 1B, and is it 1C as well now?
Yes,
65 to 74 portion of 1C.
65, yes.
65 to 74. So the really confusing thing is those hospitals are following the state guidance. And when the state changes its guidance, the hospitals and the pharmacies follow the state guidance. Am I correct in saying in that? And then the county, we're taking a bit more of a targeted approach. I mean, I think that's essentially the situation. The hospitals and the pharmacies strictly follow the state guidance. Well, not 100% strictly, because suburban, you're working on a detailed plan, but they generally follow the state. So when residents hear about the state, they should know that that will apply generally for the private providers. The county is essentially working, I think of it as the county is working a bit more on equity strategy within that allocation. And, certainly that's what you presented, but I don't know. It's just how I'm thinking about it. It'll be nuanced as we go. You're now opened up to 75. I see I'm already hitting my timeline. All right, well, I'll come back, but I wanted to ask about the second dose and how people from county who went to Prince George's to get dosed the first time can get a second dose now, because there's a lot of confusion about that. So if you could answer that, please.
So I can, Dr. Gayles, if you want to do it, I'll go ahead and start and you can weigh in for me. We've spoken with the Prince George's Health Department, Health and Human Services Department, and they have indicated that people who receive, Montgomery County residents who receive their first dose in Prince George's County will be eligible and allowed to receive their second dose there as well. So they've committed to that for our residents.
So just to say, if you got your first dose there, keep trying with Prince George's County for your second dose. You don't have to try to get it through a CVS or a hospital or Montgomery County. Is that the right thing to say?
That's correct. And I believe Dr. Gayles can maybe say a little bit more about how they will get notified for their second dose.
So individuals have registered using the PrepMod system, and you're in that system. The system automatically, or the system will send you an update when it's time to get your second dose. So, for example, as you know, I received my second dose last week, and I received an email reminder to go into the system to say, "Hey, Travis, it's that time to get the second dose. You need to schedule your appointment and follow up through that process."
I see. So they will be contacted, and we're confident of that. They will be contacted. They don't have to, on their own, start trying to book appointments. They will be contacted that they are eligible for a second dose.
Well, I would encourage folks anytime there's a system, not just for COVID, but, to follow up and ensure that the process is moving forward, particularly if, you don't hear something. So I would still encourage people to be vigilant and follow that up. But the way the system works is you should get an email reminder that it's time.
Thank you.
Councilmember Rice.
So thank you very much. I'm just going to jump in. So when it comes to equity, we are acknowledging that via Giant, via Adventist, via Johns Hopkins, all of the other outside providers that are providing vaccine, that it is our hope that they institute some sort of equitable distribution, but we have no control over that. Is that correct?
Slightly. So I'll delineate that. The Hopkins platform, when they reached out to us, that was a big part of our conversation in terms of how we implement those principles. And so they were very keen to hear our discussion about how we were applying that. And the expectation is that they will be implementing similar type of equity principles in their distribution of their doses. Now, conversely, when talking about the retail pharmacies, I did ask Deputy Secretary Chan in a meeting last week, I believe it was on Friday, if the retail pharmacies were required to have an equity framework. The answer was that they were not. And so the concern that we had as health officers was, to your point, of how do we ensure that there will be equitable allocation, or will it just be a first come, first serve type system? And then obviously the natural questions launch into, well, how are the sites determined from a geographic perspective in terms of how they're distributed within communities? We did launch that question to MDH, and we are hopeful that they are looking into that this week. But as of last Friday, there was no requirement for that.
I would only add one quick point is, and I think a lot of what's happened over the last week is hospitals rushing to get doses out so they can get more doses in because they had to get that 75% threshold. And so I think there will be a greater opportunity to talk to the hospitals about equity. Even Holy Cross has asked for our equity framework to utilize in their distribution. And so I think you're going to see many more of the providers begin to integrate those principles as they meet the governor's 75% threshold and feel like they're not getting crushed for having too much vaccine. We would have preferred they'd done it at the beginning. I think everyone would, but I think that I would not say it's a foregone conclusion that the hospital will not use an equity framework moving forward.
So the devil's always in the details, though. And on one hand, saying that you're trying to achieve equity versus actually doing it are two different things. And so unless you're actually holding doses and setting aside doses for people of color, for people of lower socioeconomic status, et cetera, you're not going to achieve it, because here's the challenge. Yesterday, I spent the entire day online as I could because I was home online with my mother as I waited for the giant portal for 4 hours. And then it came back saying that there were no appointments available. Fine. How many people have that opportunity? How many shift workers? How many folks who have non-high quality broadband access? How many people have the computer? I mean, at home, we're assuming so much about what it is, and nobody's accepting phone calls. So God forbid, if you don't have a computer or are very adept with a smartphone, you're not getting an appointment. You're not even getting to the first portal to get an appointment set up. And so again, the whole system is set up inequitably from the start, and it's not your fault, right? It's a combination of the digital divide, of all the things that we know affect everyone from a health perspective that is now affecting people from a technological perspective. And I promise you that regardless of what conversation you have with folks, unless they're actually saying that I'm going to hold this vaccine for a person of color, for a person of lower socioeconomic status, you are not going to get those equitable numbers, because they're not just going to let them sit on the shelves. And the people who are demanding the doses, the people who are going to Prince George's and basically arguing on camera, saying that they're entitled to this, even though they don't even live in the county. If those folks are that aggressive in doing that, what do you think is going to happen for the stuff that we have here? So again, it's wishful thinking. I hope that we'll be able to get some of the equity worked in from the aspects of people saying, yeah, well, we'll think about it. But we have to honestly, from our perspective internally, because we're not going to have control over that, really focus on doing something that allocates doses for people in our community that we know are disconnected and need the help. Comments, Dr. Gayles, Dr. Crowel.
I would say, thank you, Councilmember Rice. The equity issue, as you know, is of absolute primary importance to us in making sure the doses are available. The distribution systems that you discussed that are outside of how we manage this process is something that has to come from and has to be done by the state and required by the state. I know that the county executive in his call yesterday with Governor Hogan raised this issue around equity and distribution, and that the governor indicated that he would look into that in terms of both the Prep Mod management of distribution, of prioritization, but also looking at how the equity goes forward in a fair way. I do know that from our perspective, just looking at the pre-registration numbers, it speaks to the digital divide issues that we have. It speaks to our need for communication. It's deeper into the community, and it speaks to hesitancy in a way. And I'm beginning to come to grips with the level of hesitancy, and not just I don't want to touch it, I'm not taking it, but I'm going to watch and see what happens to Dr. Gayles or Dr. Crowel or Dr. Before I jump in, or my next door neighbor. So we've got a lot of work to do to make sure that happens just socially in the community. The challenge for us right now is that we can make those distributions available. We can distribute and say we're going to reserve vaccines and target particular communities of color around this. Making it available and getting people to take it are going to be challenges that go hand in glove. And as we deepen our registration, we're going to have to do work on both sides of this coin to get the acceptance and get folks signed up and ready, and make sure they've got the digital access to make this work, and or other access that they need to make this work.
Thank you.
I have one additional comment to make on that, or two actually on this, but I think are key points. The one thing that Dr. Crowel did not mention about the pre-registration is that the other thing that we're selecting for is those who don't experience health disparities and are able to survive to not 75 outside of the COVID situation. And so the other reason why we see a disproportionately low number of Black or African American and Hispanic or Latino registrants is that they've experienced health disparities their entire lives and may not have made it to 75. And so we're naturally selecting for wealth and other inequality in some parts of this process. And the other thing that I want to note is you are absolutely correct, Councilmember Rice, that the whole process selects for some inequity, because if we hold doses back to ensure that our Black or brown residents get them, the state sees that we're not giving out all of our doses and gives us less the next week. And so it's sort of like this cascading effect of inequity that plays out one after the other. And so it's you are correct that it is ingrained in the system, and I think Dr. Crowel has said the system fights back, and we're happy to grapple with and fight the system, but you're correct. It's going to be hard. This will not be a perfect process for equity. Our goal is to try and make it as good as we possibly can in this way. But you are correct that it's not. We're going to be struggling with this question constantly. We can develop a process. We're going to tweak we're going to have to constantly be revisiting this issue to make sure we're doing it.
That's right.
Councilmember Friedson.
Thank you. And a couple things, some of which have been raised, so I'll just quickly echo them. First is the fact that the governor and the county executive have gotten together and had a productive conversation is a giant leap in the right direction. It's long overdue. I think there's, both sides can accept some responsibility, but I'm very glad that that is happening. We need more of that, because we're not going to solve these problems without conversations like that and without conversations between the executives. And so, yes, and we need a lot more. So hopefully that will continue. I think all of us are reassured and relieved to hear that. I echo Councilmember Navarro's comments about the need for centralized responses. The idea that I'm texting until 2 o'clock in the morning, Dr. Stoddard asking, is this a legitimate email that a constituent is asking me for? Should they show up to their appointment tomorrow morning, or not? Are they doing this the right way? What they're hearing about this site, what's the response to it? I mean, there are emergency responses that we need in real time, and the system that we have is just way too slow in terms of communication. We don't have the information fast enough to get it to residents, and certainly residents aren't getting it fast enough. And unfortunately, because we're not providing it to them fast enough, they're getting it elsewhere, and more often than not, they're getting the wrong information. And so I just want to echo that. That is something that we can control. We can't control the number of vaccines that we get, but we can control the information that we provide and how quickly we provide it. And again, if we need more personnel, if we need more resources, if we need to reorganize and restructure the government, we have to do that yesterday and get that done. So I just wanted to echo that. Also agree, I've said it privately, I'll say it again publicly, with Councilmember Reamer's request for a plan for vaccinating teachers. Very happy to hear about the Johns Hopkins partnership to help with that. I don't think we need to harp on it here, but it would be very, very helpful for all of us and mostly to the public and to our teachers to understand what that's going to look like, what the timing is, what the expectations are, because that's a group not only is a top priority, I know, for all of us, but also something that sounds like is, at least to a certain degree, within our understanding and control now to see, how that will move forward with specific partnerships. That's very positive. Some specific questions. According to the state orders, there's 100 doses that the county health department has to hold back for educators specifically, now that we're doing this partnership with Johns Hopkins. My understanding is that those 100 doses for educators can be used for childcare workers. Could you just explain what the plan is for that and whether or not those 100 doses, rather than being held back for educators, will be used for childcare workers?
The Councilmember Friesen, I've reached out to the state for further clarification to get more information in terms of just the level of question that you just asked. I'm waiting for that clarification. Once we receive that information, then we'll be able to roll it out in the direction that the state that requires or desires us to do so.
Okay, great. I'm happy to follow up as well from what I heard, just to give you the limited amount of information that I have. Childcare workers are educating right now. I think we can all agree putting themselves at risk right now. So if that is allowed, and as soon as we know it's allowed, I hope that we can move forward.
We agree entirely with you. It's just, making sure that we have the appropriate information and we do it per the state's, requirements. There are a couple of key areas where there have been directives put out where there is a lot of gray area and confusion. And so we're just hoping to clarify that before we make any actions public. Because certainly, there's a high volume of childcare providers out there, and we do agree that everybody needs to be covered. We just want to make sure we do it within the spirit of the program.
Totally understand. But I will say childcare workers disproportionately represent some of the equity priority groups that we're talking about: older, women, people of color. I mean, that is a disproportionate number of that profession in particular. So I think we all agree. I wanted to put it out there. I appreciate your response, and it's a totally understandable to make sure you confirm from the state before moving that forward. But
even while we're doing that, Councilmember Friesen, we are looking. There was a survey that was conducted by MSDE of childcare providers. We've already started to pull the data from that survey so that we can start to see. Because again, like you said, we want to make sure that we'll have an equitable pool to look at once we're ready to do. Once we get the direction from the state to go ahead and do that. And so we've already begun in the background pulling, getting that information from the state from that survey so that we can apply it to our Montgomery County childcare providers.
I'm glad to hear that. Thank you. Independent living facilities that are not covered by the CVS and Walgreens pharmacy partnership. Some examples that I am well aware of, like Ring House, Hebrew Home, but we hear lots of these organizations. Is there a plan that the county health department has, either directly or through some other partnership, to cover these vulnerable older adult population centers?
Yes. We actually received a similar question from some of the state delegates last week, and the same answer that we provided to them, we'll share. We requested that information. I believe Delegate Kelly did send that information to us. And so the team is looking into that in terms of how we can best be able to assist them. As it currently stands, as we were in that initial conversation, making it available to those individuals who can access the county sites. Now, doing something beyond that at this point in terms of scheduling an on-site type distribution is something that will require additional planning. But certainly any of those residents who are age appropriate per the county designations are eligible to receive vaccines. We had this conversation on Friday, so allow us some time to work through with that in terms of how we integrate that within moving forward within those groups. So
appreciate that. As soon as you have more specifics on that, if you could share, we don't have to wait.
Yes, we will do.
That would be very helpful, and I think share with the delegation obviously as well, since clearly they're interested. Thank you for that. Question about teacher. If a teacher is in 1B, how do they register? And that's my last question here. because we're in 1B. That's just not clear. If there's a plan to vaccinate teachers, but we're getting lots of questions from teachers of where do they go? Do they wait? Do they wait
I think
until
any of us
the?
can answer this one. Go ahead.
Yeah.
You muted, Dr. Gayles.
Yeah, Dr. Stoddard can address it.
Yeah,
I mean,
so first off, number one, like we said, and now that it's 53 minutes for those counting, we should have a 1B, 1C registration up for teachers. So non-public school teachers should go, I mean, any teacher, non-public or public, can go ahead and register through the site. For MCPS, we will be working directly with the MCPS administration for them to identify in name the faculty and staff that are in their phase 1. They have approximately 8,000 identified. They will identify those people, and they will they'll be sharing their information directly with Hopkins in the MyChart system. And so obviously they won't need to register if they want to feel extra secure and pre-register today as well. The system will allow them to do that. And similarly for our non-public schools, they can pre-register starting today. We will also be having a meeting with the non-public school administrators on Friday to talk through their processes as well. And so MCPS will likely, that'll be a direct contact with Hopkins, at least for this first phase. And I want to say, extended to your further point of having a multi-week plan, the challenge of a multi-week plan is that I think it's very likely that Hopkins will not get another 9,000 doses next week. Because what will happen is the other hospitals will have demonstrated they've given out their doses, and they'll all get a share of that 9,000 to them. And so then we will have to have a negotiated deal with Holy Cross, Adventist, Hopkins, and MedStar that may cover our teachers. So that's the challenge of a multi-week plan, is that it's only as good as the distribution scheme that the state utilizes. And so that's going to be the big challenge of that.
Understood. I'd like to be put back in the queue. If my questions get answered, I'll ask to be taken off. Thanks.
Council Vice President Albornoz.
Thank you. This is a question regarding reopening. We're starting to get questions, understandably, from restaurants and others why Montgomery County isn't moving forward with in-house dining. I'm going to make a couple comments and then I have a couple questions. This shouldn't be controversial, and I know my colleagues all agree. Our number one priority for reopening has to be our schools, and that has to be done safely. It has to be done thoughtfully, and it has to be done, obviously, strategically. So that includes PPE, that includes sufficient testing, that includes, and most importantly, an appropriate release of vaccines to our faculty and staff. That is a moral obligation. And as we know, we are all deeply concerned, deeply concerned about where we are right now. And so while we have been focusing most of this conversation around vaccine dissemination, understandably, we can't lose sight of the issue of community spread. And we have done a really good job, and a significant credit goes to our constituents, who we were bracing ourselves for the holiday season and what would happen as people traveled around. But once again, Montgomery County residents have stepped up, which we are so appreciative of. But we have to be honest and acknowledge that some of the policy steps we've taken have also contributed significantly to that community spread being controlled. And we know, unfortunately, that in-house dining does lead to community spread issues. And so we have to do everything that we can, continue to do everything that we can to ensure that we head in the direction of reopening our schools. Acknowledging when neighboring jurisdictions make different policy decisions at us, it raises questions and challenges, because if somebody just drives a couple miles to a restaurant across the border, then it challenges us. But we have to continue to do everything we can to contain community spread here, so that once these other factors are in place, we can safely reopen our schools as quickly as humanly possible. Can you talk a little bit about community spread, Dr. Gayles? This is a regurgitation of conversations we had before, but just remind our residents about why the steps we take and these very painful policy decisions are contributing to controlling community spread right now.
Sure, Councilmember Albornoz, actually, given your very, I can't think of, great descriptions of where we stand and a number of issues. I think if I can borrow you to be my spokesperson on these issues moving forward, I think you very eloquently laid out the concerns. And so in looking at the information, I know Dr. Stoddard has presented in a number of recent conversations. For example, we've seen, I think, about a 40% decrease in the number of restaurants.
40 to 60,
40 to 60% decrease in the percentage of restaurant employees who've tested positive for COVID since that restriction was put into place. So we have seen benefits from those actions that clearly lay out why they were important. So it's not only for community spread for individuals in those spaces, it's also protecting the people who work in those spaces. And so we have been very clear that we will continue to monitor the trends. And for example, while we were on this call, I received an email saying, we are throwing restaurants under the bus when Prince George's County, their numbers are worse than ours. And so why aren't we opening up restaurants? I can't speak for Prince George's County, but what we will say is we will continue to look at the numbers, not only in terms of the community transmission, as you pointed out, with test positivity and case rates. We'll also continue to look at our hospital numbers. And if we see that there is room to be able to make some provisions, we'll move forward in terms of recommending that. But a lot of what we're trying to do, and consistent with, I'll revisit the conversation we had when we made that determination to restrict in-person dining. To your point, everyone on the call agreed that the goal was to get schools open and to drive community transmission levels down. And so that's what we're trying to do. Now we have a new player who's a part of the conversation, and that is vaccinations. And so the hope is that as we increase the scope of that and get educators and everyone else covered, that also minimizes the potential risk of exposure when these different activities open up.
I have a technical question. I'm going to follow up and save everybody time. I'll email it to you, Dr. Gayles. So I'll follow up by email. Thanks.
Thank you, Council Vice President. Can I just follow up on that last topic? I fully agree schools need to go first. In the spring or summer, when we were shutting down in collaboration as a region, there were conversations between the county executive, Mayor Bowser, county executive also Brooks, about doing things in a more coordinated fashion. Have those been happening as DC and Prince George's reopened their restaurants? And are you in touch with your counterparts in those jurisdictions on the same matter? Because I can tell you, we're all going to continue to be concerned about people are calling restaurants in Silver Spring saying, are you open? Oh, you're not. Okay, I'm going to go make a reservation in DC. I'm sure the same thing is happening in Bethesda and elsewhere. Can you tell us what the status is of cross-jurisdictional coordination?
Well, I can say that, again, health officers, we're not elected officials. We provide guidance, so we don't make the ultimate decisions. Sure. We provide the guidance. We speak regularly. In fact, after this call, we have the National Capital Region health officers will be meeting to discuss, where we stand in our pandemic responses, as well as, our vaccine allotments and those kinds of things.
I guess I'm asking, did we or did the county executive urge those jurisdictions not to reopen? Because obviously it's not helpful for public health in those jurisdictions or in the region or in Montgomery County.
I would say, yes, the county executives did talk about this. I think that I don't think it's coming from the public health or the emergency managers for those jurisdictions to be opening. I think we'll be candid. Right. There are pressures beyond that. There are, and look, political leaders have to balance out issues in certain ways, and those go beyond political. There can be economic considerations that are being built into there too. And I think we have consistently given more deference to the public health protections. I think in this case, as we talked about, everyone's strong desires to get schools back in session, and we want this to be the last closure as well. I think the jerking back and forth of opening and closing is also not welcome. We heard that pretty early on from our restaurants as well. And so we firmly believe we opened too early in phase 2 over the summer. I know that was, and so we saw our numbers change pretty quickly as soon as we opened up indoor dining over the summer. And not to say that we're going to be in this phase for 6 more months or even 3 more months or 2 more months, but I think that we're trying to be sure that we're heading in the right direction and that the numbers are low enough where that we opened up indoor dining. We don't see a sudden recurrence, particularly in light of the fact that we now know this other strain, which is more transmissible, is spreading in our community. We don't know it in Montgomery County, but if it's in Northern Virginia and it's a non-travel related case, it does not take a scientist to postulate that we've got it spreading in Montgomery County. And so I think we're just, we want to be sure that we're doing the right thing and that, we're not going to contribute to a significant increase in cases and corresponding loss of life.
Absolutely. Thank you. Councilmember Katz.
Thank you very much, and I will be quick. I agree with the Council Vice President on that schools obviously are a number one priority and should be, but we do have to consider, as was mentioned, I'm not going to belabor the point, but as was mentioned, the people in Montgomery County are going to restaurants and other places. And so therefore, I don't know that we're necessarily helping our businesses, though not everybody is going to another restaurant, but I don't know that we're helping our businesses if by keeping them closed to the degree that they are. I think we need to have clear communication and continually to look at it, as has been mentioned several times today, as continually to look at when we can change it. And Dr. Stoddard, I like the way you said it, that hopefully these will be the last closures that we have. Our goal is not to close, our goal is to open when it is safe. And the last thing I wanted to say is I do want to thank you, and hopefully it will be successful that you've opened up this call center, because I think that is extremely necessary. Thanks.
Thank you. Councilmember Glass.
Thank you, Mr. President. The question I had before, I think, was addressed by Council Members Reamer and Rice, and it was regarding individuals in either independent living communities, seniors, and the connectivity or lack of connectivity that and how we're reaching them. Right, I'm telling them to go to a giant website and hit refresh for hours, and I know we've all heard those stories in the last 24 hours or so. So I won't address that, but one outstanding question I have, there is a delta between the number of vaccines we've gotten and the number that are being administered. And so I've been receiving questions about what is the cause for that. And in conversations, I've been told that we know that people are vaccine shopping and are applying for registering, pre-registering in multiple jurisdictions and multiple sites. Is that part of the problem, why at the end of the day vaccine appointments just go unfilled, or can you enlighten us as to why vaccines remain at the end of the day?
Could you rephrase it in the end of it? I'm sorry, I'm trying to.
So the percentage of doses that are used, we're at near 90%. I'm not looking at the numbers right now, but
99.6, yes.
There you go. So the doses that remain unused, do we know why? And I was presuming, based on information that had been shared with me, most of it anecdotal, that people are shopping around and just registering on as many different sites, so their slots are unfilled at the end of the day.
So there are a couple different factors that go with it. And so I think the first thing to do is to define what is meant by unused. And so in some folks' mind, we actually had a good conversation about this yesterday. In some folks' minds, they say, okay, well, they didn't use all of the doses they got for the week. That means they had to throw away the doses. That's not accurate. So we don't really have unused per se. It's just they're moved to the next day and continue to be used in that supply. Now, particularly given, the Moderna vaccines that we receive have a longer shelf life. Now, so when you're hearing stories about pharmacies going out and just saying, anybody come get the vaccine, we've used these and they're going to expire. Most of those are the Pfizer vaccines because they're stored at deep freezer, deep temperatures, and they're thawed out to be used, and you can't freeze them again and come back and use them. So that's the difference between what's meant by some that are going to expire and thrown away versus those that are unused and just simply moved to the next day. So part of what's increasing that delta for us in the last week is that there have been a number of people who have registered for appointments who aren't eligible for it. And they have taken appointment slots from others who we're trying to prioritize and get through. So, for example, if you have 600 people who show up who aren't eligible for it, then when we take them off the queue, we're trying to repopulate the schedule as quickly as we can, as best as we can, with those who do meet the eligibility requirements and criteria. So that is probably, at least in this week's numbers, probably will account for the majority of that delta that you speak of.
Got it. And if I heard correctly, that was the point, I guess, that Dr. Stoddard was trying to make before, that people who register without being in that tier, without being in that category, are impeding the process because they're leaving these gaps that are being created.
Yeah, they're actually trying to refill them throughout the day, but I mean, you open them up to people who should have them. Some of those people do take them, others who don't. So it's like it's not clear out and open them up again. It's clear out, open, clear out, open, clear out, open, clear out, open repetitively throughout the process. And so you are naturally just not able to get to 100% of your appointments filled with people who are appropriate for that tier. And that's the problem.
And I would add that at the start of this process, start of the hour, I mentioned that we were certainly the state doing something around this distribution would help, around this system would help that. But we are looking to see whether or not, as part of our registration process and moving to scheduling, we can create a unique identifier, a unique process that limits people sharing those links to schedule an appointment, and that may help to limit the number of cancellations we have to have.
More state help, more state help, more state help. Thank you.
Amen. Councilmember Reamer.
Thank you. Just a brief question. Once you've had COVID-19, you have antibodies. This science is sort of still out as to how long your immunity lasts. It certainly is pretty strong immunity. It's probably as strong as the vaccination, I guess, if not stronger. Is there any talk nationally, state, or locally about encouraging people who've already had it to wait until later in the phasing to come get vaccinated? Or do you feel that that's not an issue?
Quite frankly, I think the supply is so woefully inadequate that would not be provide a huge or cause a huge increase in the numbers. Now, there has been guidance to recommend that folks who have had a recent infection over a 90-day period to not to wait.
I'm losing you. I don't know if everyone else is as well. I'm losing everybody, so maybe that's me.
Okay, can you hear me?
Now I can. Thank you.
Okay, so it looks like it may be my connection, although I haven't moved from the same spot in the last 2 hours. But at any rate, so what I was saying, hopefully to come clearly, is
Now it's him.
Okay, so
Question that broke the internet.
We were fine before, but now we lost him.
I think we can. So I'm trying to articulate exactly where he was going with this. You're not supposed to, for a 90-day period, if you've had COVID within the last 90 days, you're not supposed to take the vaccine. That's sort of a direction. That's a medical indication not to take the vaccine. I think his point was, I don't think it's a substantial number of people who have already had the infection who are taking shots away from other people, but certainly we can be more proactive about the message around if you've had recent COVID vaccine. It may save us. Again, every dose is valuable. So I think, getting that message out there. Yes, I think we agree with that. I think that is true. And natural infection does give you approximately the same protection as the vaccine does in the limited scientific studies that have been done to illustrate that. And it'll become more clear over time exactly what maybe a couple % difference is one way or the other. But it is extremely close, and I couldn't say which one's more effective at producing immunity.
Okay, thank you. I mean, some research has showed a pretty high share of the population has actually contracted COVID-19 at some point, right? I don't know if you know what the number is, but so there's a lot of people out there who've had it already. And
it varies by location. Obviously, in some places that have been hotbeds for a long period of time, we're going to be in the maybe 30% range at this point. I mean, I certainly think that the study that was done by the state coroner's office in Maryland said there was, infection rate was much higher, and by antibodies, even people who believe it was car accident victims had substantial levels, and it was over 10%. And that was, I think, in over the summer from when those study results were collected. So it's entirely plausible with vaccine and other things. We could be in the 20% range. Don't quote me on that number, but I think it's very plausible that we're in that range. We have a long way to go to get to 60, 70% that we probably need for herd immunity, but it's not an insubstantial amount of people who have been exposed to COVID-19 for sure.
So thanks. If you could look into that messaging, that'd be great. Thank you.
Yeah, as one of those who have contracted it, I had never heard the 90-day rule. So that's helpful, Dr. Stoddard. And I'm wondering how many others are like that. Maybe we should get that out there if that's medically indicated. What would you say, though, to residents who think they may have received a false positive because they got a positive, then they got a couple of negative tests within, a couple weeks?
I would say generally, well, first off, depending on their situation, most places have options to get an antibody test, so you can actually know whether you've been recovered from it. And so if you're really inclined to be a good steward of the doses we have, and you have the availability to get an antibody test through, any number of mechanisms have them. Private providers will do them all the time. If you are uncertain that you've had it, and you think, if you have a situation like where you had one positive, one negative, and you haven't been clinically diagnosed as having the COVID and haven't been treated as such, then you certainly can. There's no harm that's been demonstrated in taking the vaccine. There has been some question about if you have active COVID and you take the vaccine, it can be a little tricky, and there's the data on that's really unclear. But if you had previous ambiguous diagnosis and you don't have access to an antibody test, getting the vaccine is not going to harm you.
Good advice. Thank you. Councilmember Rice.
Thank you. So just want to share a story with you guys. All of mine are anecdotal. My cousin who lives in Texas, his wife, who's a restaurant worker, contracted COVID in the Houston area. And their 3-year-old son has also now contracted COVID. Fortunately, Kyle has not. And so he's quarantining himself in his house and isolated from his wife and his young child. So when we talk about opening restaurants, I want to just be very careful about what it is that we're equating in terms of a business remaining open and also the health and viability of its employees, many of whom are people of color. Many of whom are people of a struggling economic status, especially in light of the fact that we've been open for, very small amounts of time, and they've been heavily impacted. So I get the push, but I think at the same time, we also need to recognize who it is that we're going to be putting at risk by opening up our restaurants. And I just want to be very clear about that. There is a balance, and there certainly is one where you also want food on the table. That's why we have unemployment. That's why we have put in money for restaurants to help and make sure that they can stay afloat and pass along some of that money to their employees as well. That's why we've encouraged people to dine outside and given them money to be able to do those kinds of things so that they can try and stay afloat. So again, I just want to remind folks about what's at stake there, because not often do we talk about those aspects, but certainly ones that are very huge in terms of what it is that we see. And I know, Dr. Stoddard, you've mentioned that having our restaurants closed has actually contributed directly to a reduction in the number of cases. So I'll say it again, having our restaurants closed scientifically via data has said that we have had less cases of COVID. So you want to open up your restaurants, you're going to have more cases of COVID. Let's just be very clear about that. So, but unfortunately, Dr. Gayles isn't here, so I'm going to ask Dr. Stoddard or Dr. Crowel my concern about having my 3-year-old second cousin contracting COVID. I had addressed this before in terms of seeing more and more children that are now coming down with COVID. Do we know, have we heard anything more about trends? I know that we're so focused on vaccine that we're not talking as much about COVID cases. Have we still been tracking that, especially since we're talking about opening up our schools, especially with young children who we thought, had some sort of immunity, and now we're seeing that that immunity isn't as bulletproof as we thought it was. So what's the conversation there? What are we learning? What is the data telling us?
I'm pulling up the report that we get on this particular number, and so in the 0 to 9 age group is relatively flat over the last 3 months. It's sitting around 6.7% of our cases come from this age group, and we've seen a slight increase by maybe about 1.5%. It went from about 10% in October, mid-October, to about 11.5% as of our latest data point for 10 to 19. They are still respectively, let's see, the third highest category for 0 to 19, ahead of 40 to 49-year-olds and 70 to 79-year-olds. And the 10 to 19 is also ahead of the 60 to 69 age group. So the young groups are actually behind sort of the most of the core adult working population, so 20s, the 30s, and 40s. But they are, sort of in line with or near to some of the older populations. So it's a typical bell-shaped curve where most infections tend to occur in the middle age groups, but and then along the ends for the older and younger population.
So I would.
Sorry. Go ahead.
No, go ahead. I thought you were done.
I was just going to say, in what we're seeing, I think the real concern about this new strain, particularly in Europe, is they're seeing a pretty marked increase in youth infections in Europe as a result of this strain, just based on its transmissibility. And I think it lends some credence to the notion that the traditional or I guess wild type or standard COVID strain, depending on how you want to phrase it, is less transmissible in young children. It probably is. I think that's what the data bears out in some cases, but less and 0 are two very different numbers. And I think that we should be clear about that. And so I think the concern is if we do see it shift over, and I think every public health official who I have talked to and read from believes that this new strain will take over in the United States at some point. Likely we're talking along the March, maybe April timeframes. And if it is more transmissible, I would expect to see that the distributions of cases will shift in terms of who's been exposed. And so that is a real concern.
I would add to that we have a couple of things. We have shut down in this area a lot of the contact that our kids have, and a lot of opportunity for transmission of the virus amongst kids has dropped off over the summer and over the year. And the new strain is unpredictable. We don't know what happens with that new strain as it comes into the system. But we also know that this virus children don't necessarily show the same symptomatology. We don't know yet how many people have actually been infected that show no symptomatology, and how many children may have been infected that have shown no symptoms at all, but have been certainly capable of passing that virus to someone else. And I think that is one of the issues that we have to continue to watch and be mindful of as we work to bring children back into schools and think about reopening.
Thank you, Mr. President.
Thank you. Councilmember Navarro.
Thank you. Quick question regarding the issue of people shopping around and then being able to make appointments to get the vaccine, et cetera, and how that affects, other places where they may have already signed up. When I communicated with Delegate Ariana Kelly this weekend, she had a question about childcare, which I know was answered. But I asked her about this in terms of the state, what could the state do to help us in terms of this issue? She mentioned something about Immunet and us here then having to literally look at Immunet and then be able to identify who had gotten vaccinated and take that out of the system, et cetera, which I imagine is like a huge undertaking. But I was just curious about that. And, what do you say about that particular issue? So that's one question. And then again, the only other thing I will say as I was listening to the issue of the new strain is that in my mind, I guess what we're all trying to do is like a race, right? A race against time, because we need to vaccinate as many people as possible before this new strain does take over. I mean, that's a real concern. Just wanted to make that commentary. But regarding Immunet and our ability to then have to literally go, check to see who was vaccinated on a daily basis. Is that something that we even do, or how complicated is that?
Councilmember Navarro, first thing, I think you're right. We are in a race against this new strain to get as many people vaccinated as possible. But to your first question around, it's the PrEP mod system that's at issue. Immunet is the system that physicians register on for this system. So we're talking primarily about the PrEP mod system that we need to state to do some work on doing an integrated job, better job of integrating across the system. We are at present doing sort of hand checks of the people who are scheduled for appointments to make sure that they are in the queue appropriately, and doing cancellations of appointments where they have not been specifically offered an opportunity to schedule an appointment by the Department of Health and Human Services. That is a labor-intensive process. We have asked and are working with Department of Technology Services and our IT department to be able to do a crosswalk between the people who are pre-registered and the people who've actually scheduled appointments in the system, to identify people who are inappropriately scheduled appointments, and then to figure out a way to quickly cancel those appointments and ask them to come back and reschedule at a later time. It doesn't exist at this point. So we have been wrestling with just this issue, just hand looking at the system and identifying folks who should not be in the system. So if we can get that up and running, that'll simplify that process for us. And ironically, it may have the effect of allowing us to then reschedule those open appointments to folks who are in the queue and should be next in the queue.
Thank you. I'll circle back with her because she specifically mentioned Immunet as that particular vehicle, but I'll circle back with her. And I think that as we are also approaching, the governor, et cetera, it doesn't hurt to point out these particular barriers that we here are facing, to see if there's any way that they can address that sort of, from the state level, or at least we can figure out a way to connect all of these programs and all of these systems. I think it'll be a huge help, given that this is a massive undertaking. There is no doubt. And we could say that we knew it was coming. So it's not as if, the state level, I think that it's not like this is a surprise. But right now, given that this is the race against, time and these new strains, I do believe that whatever feedback we can give them, as well as work with our delegation. I think at least Delegate Ariana Kelly seems to be super involved and giving her committee assignments. And so we should just use every single opportunity to figure out ways to give feedback in terms of what would help not only us, but then help the state as we address, this very important interconnected issue. Thank you.
I meet with delegates Kelly Collison and Senator Feldman every Monday morning to talk through issues that they can help us with from the delegation level. And then we also meet obviously with the delegation every other week as a total. So we are utilizing the delegation to help us do more advocacy, as well as understand where we can work with the state to do things better.
It's really good to know if there's a way for that, conversation loop to be addressed, because I know we also have our state ledge. I don't know if maybe that would be a good time to just get some sort of updates on what the conversations have been, Dr. Stoddard, and then what issues maybe were resolved, so that way we can check that off our list. But maybe if there are other issues that have come up, that's another avenue. So I'd like to request that, President Hucker.
Sure.
If possible.
Thanks. And I'm also in the meetings with the state delegates weekly that have been very helpful. But yeah, no, that's a good suggestion for adding to the state legislative meetings. Dr. Gayles, were you raising your hand?
Yeah, so I wanted to clarify a point and apologize about the technical difficulties. I have no idea what happened, but I feel like my last response was truncated and cut off. And so I wanted to clarify related to the 90-day period. So the question was asked in terms of kind of an immune response. So individuals do, the thought is that they can have as an antibody present upwards to the 3-month period. And so there is no hard and fast rule to say if you have COVID that you have to wait 90 days to get a vaccine. There has been some literature that suggests that because you are producing antibodies, you would have protection for up to that period. So you may consider waiting to get the vaccine during that time period. So there is no rule out there that says you have to wait during it. Now, the recommendation is that while you are acutely ill with COVID-19, it's not recommended that you get the vaccine during that time period, which is consistent with, the flu shot as well as a host of others. So I wanted to clarify that to make sure folks at home understand what I meant by that. But at the same time, having individuals who have had COVID not get the vaccine would not cause an appreciable increase in doses. And so, we encourage folks who've had COVID to get the vaccine as much as we encourage others who haven't to get the vaccine as well. So just wanted to clarify that.
Glad that you did, because I was about to clarify too, because as I was getting text, I'm like, that wasn't as clear as we needed to make it. So I'm glad Dr. Gayles did.
Thank you. I don't see any other requests from my colleagues. We're a few minutes over. Thank you all so much for all your hard work and leadership. We'll see you. Oh, council member.
I had asked to be in the queue. If I could, just a couple quick follow-ups. One, we talked a little bit about the not using all of the vaccines because of canceled appointments. Obviously, the main issue here is that the state system is not intended for this type of use, and there's some major problems there. Obviously, we can't control that. We've asked for some type of unique code or improvement to that system. I think we all share that would make everybody's life easier, including our residents, many of whom think they're doing the right thing. They're following what the governor has said makes them eligible. They get a link which doesn't have all the information, and they quickly sign up for it. And I don't think that's oftentimes on them. That's on a system that doesn't work and isn't doing what it is intended to do. But I am wondering if we can have a confirmation or some type of other effort. I imagine now that we're moving into 75 plus, it's much easier to do that if it's age-based rather than profession-based in terms of eligibility. But it would seem to me that even if we don't have a system on the front end, which would be ideal, to be able to confirm folks and spit them out if, as they're trying to register, if they're not eligible, et cetera, being able on the back end, at least, to have the staff on our end to make sure that the people who are scheduled for the next few days are actually eligible to receive the vaccine, to avoid these types of unfortunate confrontations that put people's health at risk, I believe, and put everybody in unfortunate situations. So just wanted to get a sense for that. And then similarly to that, if there are no-shows, so I think some of it might be people being turned away. Some of it might just be, people don't show up for appointments. I mean, that happens for every doctor everywhere. Dr. Gayles probably knows this, better than anyone with his background. Could we have a wait list? I mean, people are desperately trying to get this, where you have a wait list for a period of time, set number of appointments, either the morning or the afternoon, that says, you might not be in the queue until next week, but this week we'll put you on this day on the wait list. Stand by, be ready for a phone call, a text, et cetera, and within 1 hour, be ready to go to X site. Is that possible to be able to reduce some of these challenges?
Well, to address the question, we actually have not had a ton of unused doses, if you will. Again, our percentage distribution was 99.6% of what we received last week. So we're talking about a very small number of doses, again, that get rolled into the next day to help staff those clinics. We have had a wait list in place since we started administering the vaccine. So we have had that construct in place for a number of weeks now, recognizing that if there are no shows or cancellations, that we can pull people off the wait list and call them and get them in. So that infrastructure has been in place from the very beginning. And to the first point, and this actually brings up something that Dr. Stoddard mentioned in terms of the messaging that is put out. So the first layer of, so everything you mentioned in terms of security provisions, we completely agree and are, have given that feedback to the state and hopefully even using some local expertise to figure out systems around that. But we do explicitly explain to people, do not share the link. That's been called out in a number of different ways. And I think there was a discussion yesterday to talk about how to make that more visible on the notification that goes out. And every attempt to cancel appointments as best as we can were made in the last week to try to get people to scrub the list for individuals who were not eligible. And yes, there were some who still did have the appointments and came, and we had to let them know that they weren't eligible to come forward and move forward. We do hope that moving forward now, to your point, is that age is confirmed by your identity. So if you have an ID, you're eligible or not. And the team is working hard to try to, again, in the absence of having a control mechanism in the system that's built in already, to try to cancel as many of those appointments for individuals who aren't eligible as quickly as they can in terms of the system, to thereby increase the appointments open so that others who are eligible can quickly utilize those and take advantage of them.
I appreciate that. The only thing that I would say, sorry, go ahead, Dr.
Yeah, you clear the folks out as we talked about, and you have two choices at that point. Either you can lock out the clinic, or you can leave it open so that people who are supposed to register take the slots that you've now freed up. But if you leave it open for those people who are supposed to take the slots that you've freed up, the people who have the link who fall outside those categories can also scoop those slots back up again. And so it's sort of because of the way the system works, you either close the clinic to everyone or you open it to anyone who has a link, and there's no in between there. And so if you want to fill out the slots for a clinic, you have to open it back up, and then it gets refilled with people who are falling outside the categories, and you try and re-clear them. But some, given that it's a constant back and forth throughout all the way up until the time that someone comes to get vaccinated, you could end up canceling someone out at 11 o'clock in the morning.
It's obviously a huge problem. This isn't an accusatory or a blame thing. I do think that I just saw in the press release this morning that this is the specific email you will get your county health department appointment from. Now that we know that, that's the first time I have seen that. Now that I know that, I can then share it with somebody to say, what is the email address you received this appointment from? And if it's not this email address, then you are not going to be eligible and they're going to turn you away. That puts us in a much easier situation. So I appreciate that. And I think we need to be thinking more of that. It's not perfect, but it is better to be able to have something tangible and specific to say, here's the address, rather than saying it's from the county, it's not from the county, specific email address. Last point, and then I know we're over time here. The 18,825 doses in the county. I know earlier you said it doesn't matter where Montgomery County gets its doses and who's administering them. We just want Montgomery County to get it. I agree, but for residents, it does matter because it changes who is eligible. It changes how they register. It changes how they find out about it. And so it's extremely confusing. And so it does have a major impact. And so I'm wondering, these doses, there's 8,775 through Hopkins and Suburban, 5,500 through the Montgomery County Health Department, 1,950 to Kaiser Permanente in Gaithersburg, 1,000 to NIH, 1,600 for Giant. They all have different rules. NIH is just for their own employees, for instance. Ours is just for 75 plus in the county health department. Suburban has the 3-tiered system you talked about earlier. I'm not entirely clear what Kaiser Permanente is responsible for. And I've been sitting on this briefing for 3 hours and I'm in these meetings every day. So is it possible to list that information every week? We know that information, you know that information, you're working with these folks every single day. On the county's vaccine website, include, here are the places where Montgomery County has received, here's the number that they have received, and here is who is eligible at each site, and here's where you would go in order to register for that site. It would, making it clear that the county doesn't control that, but, we do have the information. I think it would go along the lines of, what I've been saying previously, that we can only control what we can control, and we need to over communicate what we can't control. And I think we can over communicate that rather than just giving a link to the state website and saying, go to the state website, which has information that somewhat conflicts with the information we're trying to share. If we had one place that had everything that people were looking for and needed, it would streamline things a little bit. So just asking if that would be possible.
Councilmember Friesen, we will look, we've started, and every week we have a conversation about what are the things we need to be updating folks on daily, and that list kind of grows and evolves. This is a new wrinkle that, yes, we're going to have to add that to the weekly and ongoing communication.
We started yesterday. We actually added the link that the state provides to find other clinics onto our website. We're going to probably build it out so that you can actually list the direct opportunities and what categories those opportunities are vaccinating. So that is an addition that we're looking at for the website for sure.
That'd be terrific. I think specifically the number of doses, who is eligible, so you didn't have to click to find that out, and then the link so that somebody could see, you know, if I'm in this category, here are my 3 options, here's the link that I would go to. I think the more information that we can provide to people that is accurate, the less confrontations and issues and problems and uncertainty and anxiety that we will create. It's not easy. You're in a nearly impossible position. I appreciate and sympathetic towards that. But again, let's control what we can control and over communicate what we can. Thank you.
Sure.
Terrific. Thank you all again for all your help and assistance to our residents. We'll see you again soon.